Greetings from Bangladesh. This is Dr. Shahjada Selim, Associate Professor in the Department of Endocrinology, Bangabandhu Sheikh Modi Medical University, Dhaka, Bangladesh, and General Secretary of Bangladesh Endocrine Society. I am very much grateful to the 7th International Conference of Egyptian Cardio Diabetes Association, and especially I am very much grateful to Professor Noshe Shoaib for the Yusuf for the invitation to be part of the conference. The learned audience, I am again very much thankful to the organizers to select a beautiful topic like advances in obesity therapy, as the world is shifting from normal weight or underweight to obesity, and this is not the problem of the advanced world only. Even in the developing and underdeveloped countries, the people are becoming obese, and not only the obesity, several others non-communicable diseases are now the part of the obesity. So I will cover my topic by saying the medical complications of obesity and benefit of weight loss, approved medications of obesity, available anti-obesity drugs, and unmet needs. This should be very well understood. Gut hormones and the weight-reducing drugs in the phase 2 and phase 3 trials. So why should we focus on obesity management? Because obesity has several complications, and in a single person, the complications may not be totally present, but one or more of the complications may be present in many of the persons who are becoming obese. The central of the obesity complications is the cardiometabolic complications, starting from dyslipidemia, especially diabetic dyslipidemia, which can lead to atherosclerotic and other complications. And second to dyslipidemia, the hypertension and pre-diabetes, and many of the pre-diabetes of today will be diabetic in tomorrow or day after tomorrow. So this is one burning issue in the globe. Now the metabolic fatty liver, metabolic other disorders, starting from fatty liver disease, is also becoming very prominent in recent world. For the women, the polycystic ovary syndrome are very much intimately associated with obesity, and ultimately diabetes and cardiovascular diseases will ensue. Not only that, the biochemical and other parameters will be there. The person with obesity are heightened chances of this motility or disability, gastroesophageal diseases, lung function defects, osteoarthritis, and joint pain, sleep apnea. This is very much associated with, again, cardiovascular diseases, and urinary incontinence may be present in many of the obese persons. Other factors, especially for the men, the androgen deficiency or testosterone deficiency, the sexual dysfunctions, and that can even lead to subfertility. There are several cancers which are highly associated with weight gain and obesity. Gallstone disease is very much important for the obese people, and psychological disorders. Again, it is very commonly encountered in the overweight and obese peoples in the different part of the world. So we should be very much keen to identify the obese people with these complications. Now, if we go for weight reduction, what benefit we can expect? So I am showing by percentage of weight loss and the benefit from up to 5% initial weight loss. We can expect that the blood pressure management will be easy, and this lipidemia will be improved, and the hyperglycemia also will be easily manageable. By reducing 5 to 10% of the initial body weight, we can have the prevention of type 2 diabetes mellitus or fatty liver disease, and dyslipidemia will improve. By reducing body weight by 10 to 15%, cardiovascular diseases and non-alcoholic fatty liver disease, especially NASH, can be improved. And by reducing body weight more than 15%, type 2 diabetes remission, the fascinating area of diabetes management nowadays, can be achieved. Cardiovascular mortality can be halt or reduced, and heart failure in patients with obesity can also be improved by reducing body weight more than 15%. But how we can achieve reduced body weight? Several other methods like the at the corner of the lifestyle obesity management is the lifestyle modification. Though today we will not focus on this. Next to that, pharmacotherapy and surgery. So I shall be very much keen to discuss pharmacotherapy and surgery as the today's topic is advances in obesity therapy. So we can start to this one. At the beginning, we have to look in the globe the drugs that has been approved by different authorities for the obesity management. I am showing the simplified chart that has been approved by US FDA up to June 2024. Several medications are there, starting from naltrexone, bupropion, phentermine, orlistat, phendidiamine, diethylpropion, benzodiazepine. Tirzepatide, the most prominent anti-obesity drugs nowadays, semaglutide, liraglutide, and other drugs are also in the use. But if we compare the drugs, by percentage of body weight reduction or total body weight reduction in kg, we can see that several drugs have the several weight loss potentiality. But the dose is the dose of the drug is the main determinant for the weight reduction. At the highest level, we can expect the body weight reduction by tirzepatide 15 milligram. It is up to 20.9 kg. The next to that, tirzepatide 10.5 milligram. Following that, tirzepatide 5 milligram. Semaglutide is also very much important drug. It can reduce body weight by 7.9 kg. Semaglutide also at the initial stages, it can achieve body weight reduction up to around 15 kg. Other drugs, liraglutide and the combination drugs has weight reducing potential, but the level of weight reduction is not very much fascinating. Now, the bariatric surgery, the very important one, but we can have the comparison of bariatric surgery of the Roux-en-Y and sleeve gastrectomy. We can find that the difference of weight reduction is 31 versus 25%, and after 5 years, 26.9%. But one thing we should keep in mind that after 12 years, the patient with bariatric surgery may start body weight regaining. So what will happen? The future study will focus on that. Now, the main drawback of bariatric surgery is immediate and late post-operative complication, lifelong follow-up, weight regain. As I show that after 12 years, there is chances of weight gain. Now, not every obese person wants for it, but it is again costly one. So an oil facilitated centers is needed, and no surgical capacity to operate on every person that qualifies for bariatric surgery. Again, it is time consuming as well. Now, what are the unmet needs of anti-obesity drugs in the world? The huge efficacy gap regarding weight loss between the currently available pharmacotherapies and bariatric surgeries, and heterogeneity in the treatment response with GLP-1, and the highest effective drugs are injectable and may not be considered by some patients, because many of the patients will be very much afraid of getting injections regularly. So now the main concern is of the anti-obesity drugs is the gut hormones. Several gut hormones are in use. I am coming one by one. The GLP-1 is the initial drug to be used for the anti-obesity drug, but following that, the other GIP and other combination drugs are in use. But in near future, we expect that there will be triple statins, and the fourth drugs combination may also be available in the market. So starting from semaglutide, several drugs or for glipron, denolipron. These two are not available in the other parts. Eli Lilly and Pfizer also started marketing of these two drugs. But the tirzepatide, the main drug that has been marketed by Eli Lilly, but it can be found in our country and other parts of the world, and it shows the promise of weight reduction, diabetes management, and the adversity is superior to GLP-1, other GLP-1, because the GLP and GIP counteract the adversity. Tirzepatide showed that the highest weight reduction potential up to around 21 kg comparing with placebo and other drugs. So this can be used in the other part of the world. Amylin agonist and in combination with the GLP-1, this is in the pipeline. So in near future, we can expect that this will be one of the most important drug for obesity management. Now, GLP-1 and glucagon agonist is also theoretically it's promising, but we are not having the drug at our hand. GLP-1 PYY agonist, again, this is the trial drug. So in future, we may have this drug in our hand to use for the diabetes, obesity management in the several parts of the world. But if we compare the potentiality of weight reduction by the drugs, we have also be very much interested to focus that the drugs, whether it is injectable or oral. So injectable one is may not be liked by many of the person. So at the end, to summary point of potential future of obesity treatment on the gut hormone, except of the approved GLP-1 receptor agonist and GLP-GIP co-agonist tirzepatide, multiple other gut hormones like amylin, glucagon, POI are being tested, and we can expect that many of them are will be used in the drugs. But phase 3 and phase 2 drugs also are promising, but we are waiting for those drugs to have our future use. Set melanotide, the another drugs, Bimar, Bimagrumab, again the promising drug that has also highest potentiality to decrease body weight. Now the setmelanotide is now in the phase 3 trial, and the scientists are very much interested to have this drug at their hand. So at the end, I can say that along with lifestyle modification, several drugs have been tried, and dual creatine or triple combination or a combination of food drugs have the highest promising effect of weight reducing, but we should not forget the lifestyle modification, diet and exercise that will have the low cost benefit of weight reducing. Thank you for your kind attention. And if you have any question, I will be very much happy to answer to those.